This is Lauren Littlefield, and I will be discussing the gastrointestinal changes that occur in the older adult. So, there are many physiological changes that happen in the GI system as people age, especially after 65 years of age. Changes in digestion and elimination can affect nutrition. As you age, the muscles in the gastrointestinal tract begin to slow down. This often leads to increased symptoms like acid reflux or GERD and constipation over the age of 65. So some physiologic changes and disorders related to those changes are atrophy of the gastric mucosa, which can lead to decreased hydrochloric acid levels. This leads to decreased absorption of iron and vitamins B12 and proliferation of bacteria. Peristalsis decreases and nerve impulses are dulled, which can lead to decreased sensation to defecate, resulting in postponement of bowel movement, leading to constipation and possibly even impaction. Decreased sensation to defecate can also lead to incontinence. So distension and dilation of pancreatic ducts change. Calcification of pancreatic vessels occur with a decrease in lipase production, and this can lead to decreased lipase levels, resulting in decreased fat absorption and digestion. So this can then lead to steatorrhea, which is excess fat in the feces because of the decreased fat digestion. There is also a decrease in the number and size of hepatic cells, which can lead to decreased liver weight and mass. And this change, also with an increase of fibrous tissue, can lead to decreased protein synthesis and changes in liver enzymes. Enzyme activity and cholesterol synthesis are also diminished. This decrease in enzyme activity depresses drug metabolism, leading to an accumulation of drugs, which can lead to toxic levels if you're not careful. So when assessing the GI system of an older adult, you want to collect all data about age, gender, and their culture. Older adults are more at risk for stomach cancer than younger adults. You want to question the patient about any previous GI disorders or abdominal surgeries. Ask about all medications they're taking, whether that's prescription, over-the-counter, vitamins, herbs, supplements. You want to specifically ask how much they take, when they take it, and what the indication is as to why they're taking it. You want to ask specifically about NSAIDs or aspirin because they can predispose the patient to peptic ulcer disease or GI bleeds. Some questions to ask the patient would be, what is your typical daily food intake, and do you take any supplements? What is your appetite like? Are there any recent changes? Have you lost or gained weight recently, and whether that was intentional or not? You want to ask about any difficulty chewing or swallowing, whether they wear dentures and how they fit. Have you ever experienced any indigestion or heartburn? What causes it? What helps it? Again, ask about previous GI disorders and or surgeries. You want to ask about whether they have a family history of any GI disorders. Ask about any pain, diarrhea, gas, or any other problems, and do specific foods cause these problems, because that can point to maybe a food intolerance or an allergy. You want to ask them about their usual bowel elimination pattern, the frequency, the character. Is it uncomfortable? Do they take any laxatives? And you want to ask if there is any pain or bleeding associated with bowel movements. And you want to make sure that there is no recent changes in their usual bowel pattern or the characteristics of their stool. And then lastly, you can ask if they've ever had an endoscopy or colonoscopy. Okay, so continuing on with assessment. You want to ask about any and all laxative or enema usage, because long-term use of these stimulant laxatives can cause dependence and result in long-term constipation or electrolyte imbalances. You also want to determine if the patient smokes or has ever smoked cigarettes, cigars, or pipes, because smoking is a major risk factor for GI cancers. You also want to find out if they've ever chewed tobacco or if they currently do. Also ask them about whether they drink alcoholic beverages, and if so, about how many per week. You also want to take a complete nutrition history because this can help you understand how well their needs are being met. And because older adults are at more risk for nutritional deficiencies, malnutrition, and dehydration. You also need to take into consideration cultural and spiritual patterns. Ask if certain foods pose any problems for the patient. For example, the spices and peppers used in cooking in some cultures can aggravate or lead to GI tract symptoms like indigestion or ulcers. You also want to know any religious observations like fasting or abstinence. So continuing on with assessment. So when you are doing a physical assessment, you want to inspect the skin and note any abnormal findings. Observe the asymmetry of the abdomen, any discoloration, scarring, distension. Look at all their skin folds, note any subcutaneous fat. You want to document what if the skin is taut or glistening. Note any location, size, and description of pressure ulcers or injuries, and observe the contour of the abdomen and note any abnormalities. You also want to observe the abdominal movement, including the rising and falling with inspiration and expiration, and just note any distress if it's there. So when you're auscultating the abdomen, bowel sounds should be listened to in all four quads. They're normally heard as gurgles every 5 to 15 seconds. They can be characterized as normal, hypoactive, or hyperactive. Increased bowel sounds result from increased motility, which can be heard in a patient with diarrhea or above a complete intestinal obstruction. Listen for vascular sounds or bruits over the abdominal aorta, renal, and iliac arteries, because a bruit can indicate the presence of an aneurysm. So when you are percussing, it can help you determine the size of solid organs, to detect any masses, fluid, or air, and it can help you to estimate the size of the liver and the spleen. So normal percussion sounds are tympanic, which are high-pitched and loud over air-filled intestines, or they can be dull, which is more of a mild-pitched, softer thud-like sound over solid organs. So when you're palpating, it's helpful in determining the size and location of the organs and to assess for masses or tenderness. So just note any signs of rigidity, which can indicate peritoneal inflammation. So you also want to assess the patient for any anorexia, dysphagia, nausea, vomiting, abdominal pain, or dyspepsia. Also assess for unusual weight loss or gain. And we did talk about alcohol intake. You want to assess for that, and also for caffeine intake, because both are associated with gastritis and PUD. So in lab assessments, they can be used to diagnose any abnormalities through testing of blood, urine, and stool. A complete blood count aids in the diagnosis of anemia or infection. GI bleeds can cause anemia and are associated with GI cancer, peptic ulcer disease, diverticulitis, and irritable bowel syndrome. Calcium is also absorbed in the GI tract and can be used to detect malabsorption. Excessive vomiting or diarrhea can cause sodium or potassium depletion. And then a fecal occult blood test can be used to detect colorectal cancer earlier. Okay, so common disease processes in older adults include colorectal cancer. The risk increases with age, and the major risk factor is family history. So in stage 0, cancer has not grown beyond the inner layer of the colon wall, but as it progresses, it moves and further along. In stage 1, it has only grown to the outer layer of the wall. In stage 2, the tumor is through the wall but not yet spread to the lymph nodes. In stage 3, the cancer has spread to the lymph nodes, and in stage 4, the cancer has spread to distant sites in the body, such as the liver or the lungs. Another common disorder in older adults is dysphagia, which is associated with lack of a gag reflex, which can occur in degenerative neurological diseases and stroke. Gastroesophageal reflux disease, or GERD, is caused by the inability of the LES to completely close, allowing the backflow of acid contents from the stomach back into the esophagus, causing irritation of the epithelium of the esophagus. A decrease in the muscular tone of the sphincter is the most common cause, and it is more common in those over the age of 40. So in peptic ulcer disease, it's an inflammatory erosion in the stomach or duodenal lining. The most frequent causes are the bacteria H. pylori and the use of NSAIDs. Stress, alcohol abuse, excessive caffeine, and smoking are some other risk factors. And because many older adults use NSAIDs more regularly, they are more at risk for peptic ulcer disease. Another one is diverticular disease, which occurs when the bowel is weakened, allowing protrusion of small sacs called diverticula. These can become infected or inflamed and fill with intestinal contents and cause an obstructive mass. And this is a common disorder that does increase with age. And a low fiber diet can also put the patient at higher risk for developing it. So some important education points for older adults. You need to drink plenty of fluids, try to stay hydrated, and try to drink 2 to 3 liters of water a day unless that's contraindicated. Educate the patient on nutritional requirements for health, any special diet modifications for chronic illnesses, the effects of age-related changes and medication on nutrition, and any resources to assist with maintaining adequate nutrition. It's also very important to educate the patient to report any signs or symptoms of dysphagia, nausea and vomiting, or diarrhea to the healthcare provider immediately. Nutritional supplements can be used to help maintain that adequate nutrition, and it is also very important to have a high protein, high fiber diet to help regulate bowel movements and improve overall health of the individual. Some more education points. Educate to report any loss of appetite, abdominal pain, weight gain, or weight loss to the healthcare provider. Educate the patient on the importance of observing your bowel habits and the character, and if they change drastically, it's good to go ahead and call your healthcare provider. Educate the patient with peptic ulcer disease or gastroesophageal reflux disease to avoid triggers like spicy foods, alcohol, caffeine, and also educate to sleep with the head slightly elevated, to alleviate symptoms during the night, and to not eat 3 hours before bed. For a case study, LH is a 55-year-old man complaining of pain and burning pressure around his stomach 2 to 3 hours after eating. He has a history of former alcohol abuse and smoking, and he has had a 10-pound weight loss in 2 months, accompanied by nausea, vomiting, and decreased appetite. So the risk factors for ulcers would be the alcohol abuse, the smoking, and a symptom would be the 10-pound weight loss, the nausea, vomiting, and the decreased appetite. So his EGD did reveal ulcers, and his biopsy sample was positive for H. pylori. Complications of gastric ulcers, they can lead to a GI bleed, hemorrhage, and perforation. So it's important to find those and get it under control as soon as possible for the overall best health of the patient.